Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, my name is Erica Stein, and I'm an abdominal radiologist at Michigan Medicine. I have no disclosures. Here's an outline of what we will cover in this talk. We will briefly touch upon the ACR-RAD systems, review the fundamentals of O-RADS, and then discuss O-RADS ultrasound and MRI in more detail. How are they similar and how are they different? Reporting and data systems are a byproduct of the American College of Radiology. These are modality-specific lexicons that also provide risk assessment. On screen right are examples of some of the RAD systems in existence. So why are these important? Well, they reduce variation, standardize lesion description, unify management pathways, and support outcomes research. O-RADS is an evidence-based clinical support system that can accurately characterize both ovarian and adnexal lesions, and also predict the risk of malignancy based on imaging features. These are modality-specific, one for ultrasound and one for MRI, and they include a lexicon with standardized vocabulary. O-RADS ultrasound and MRI include a risk stratification system that assesses the risk of malignancy based on existing data. Lesions are scored from 0 to 5. A score of 0 means incomplete evaluation. And as with other RAD systems, the higher the score, the higher the risk of malignancy. Lastly, O-RADS is intended for asymptomatic patients and should not be used in patients with active pelvic inflammatory disease, suspected ectopic pregnancy, or torsion of a normal ovary. A key distinction to make when evaluating an ovarian or adnexal lesion is to first determine if it is physiologic or not. A physiologic finding includes a follicle, cyst, or corpus luteum that is less than or equal to 3 centimeters in a premenopausal woman. These are considered O-RADS 1. Anything that is not physiologic is considered a lesion, and the next step is to determine the appropriate O-RADS score of 2, 3, 4, or 5. Here is a list of almost certainly benign lesions scored as O-RADS 2. These carry a very low risk of malignancy. Now let's talk about the everything else bucket. These are lesions that are not physiologic and are also not a classic benign lesion. These are your O-RADS 3, 4, or 5 lesions. There are certain core concepts shared by both ultrasound and MRI. Both systems assign a positive predictive value for malignancy based on the O-RADS score. A score of 3 corresponds to a low malignancy risk, O-RADS 4 intermediate risk, and O-RADS 5 high risk. There are similar descriptors in both systems, including unilocular, multilocular, and solid tissue or solid component. And whether you're looking at ultrasound or MRI, tissue is the issue. The amount, morphology, and vascularity of solid tissue in a cystic adnexal lesion will drive the score. How are O-RADS ultrasound and MRI different? While they both assign a positive predictive value for malignancy, the actual percentages are different. O-RADS ultrasound includes clinical management recommendations, but O-RADS MRI does not. However, future O-RADS MRI iterations will include this as it is actively being developed. And lastly, vascularity is measured differently for each modality, and I'll explain what I mean by that later on in the talk. Now let's talk about shared concepts between the two modalities, and we'll start with lesion morphology. These are shared O-RADS lexicon descriptors, and we're going to go over each one in the upcoming slides with definitions. I do want to note that O-RADS ultrasound version 2022 introduced a new lexicon term of bilocular cysts, which is not in the MRI lexicon. So the definition of a unilocular cyst is a cystic lesion with a single compartment. It may contain more than one incomplete septation, and this turned out to be a benign follicle. A bilocular cyst is a cystic lesion with 2 locules separated by one complete septation, and this ended up being a benign follicle. A multilocular cyst is a cystic lesion with more than one compartment and at least one complete septation. And it's important to note that fibrin strands in a hemorrhagic cyst are not considered septations. This ended up being a mucinous cystadenoma. Now we have a unilocular cyst, and we're introducing the term of solid components or solid tissue. So a solid component is at least 3 millimeters in height, and the actual definition is either a papillary projection, a nodule, an irregular septation wall, or a larger solid portion. So here we have an example of solid tissue with vascularity and a unilocular cyst on ultrasound, and here is the corresponding MRI showing the enhancing solid tissue. This ended up being an endometrioid adenocarcinoma. Here's an example of a multilocular cyst with solid components. So in this example, again, we have solid tissue with vascularity on ultrasound, and our post-contrast T1 weighted image. Here you can see there's a large amount of enhancing solid tissue, and this was a high-grade serous carcinoma. And the definition of a solid lesion is a lesion that is at least 80% solid. On the middle image here of the ultrasound, we see a well-circumscribed hypoechoic lesion with internal vascularity. And on our post-contrast imaging, we can see it is homogeneously enhancing. This ended up being a fibrothecoma. So we talked about the morphology and the shared lexicon descriptors. Now let's talk about the vascularity of a lesion. It's important to note that Doppler flow does not equal enhancement. So at ultrasound, when we use color Doppler, it demonstrates small vessels within tissue. At MRI, on the other hand, post-contrast T1 weighted imaging actually shows tissue perfusion. And sometimes lesions with no demonstrable Doppler flow do have enhancement at MRI, but we usually don't see a high-risk time intensity curve. Ultrasound assesses vascularity using a subjective color score. The scoring system ranges from 1 to 4. 1 means no flow, and 4 is very strong flow. So here we have 4 examples demonstrating the 4 different color scores. In the first example here that ended up being a cystadenoma, the solid tissue has no internal vascularity. This is our second example with minimal flow in a high-grade serous carcinoma. This is moderate flow in what turned out to be a serous borderline tumor. And lastly, very strong flow in a clear cell. Vascularity of a lesion at MRI could have its own talk with regard to time intensity curves. So instead, I'm going to provide you with some highlights. At MRI, we're able to evaluate the perfusion of solid tissue in a lesion at multiple time points using dynamic contrast enhanced imaging. We can then compare the enhancement of the solid tissue to that of the myometrium to create time intensity curves and to assign an O-RADS score. If dynamic contrast enhanced imaging is not available, you want to look at early post-contrast imaging to compare the degree of enhancement in the solid tissue to that of the outer myometrium. And here we have an illustration of the time intensity curves. So the orange curve here is your benchmark or myometrium. You can see there is an initial slope and then a plateau. This here is a low risk or type 1 curve where we have low level gradual enhancement over time, but there is no shoulder. We tend to see this type of curve with fibrous lesions such as a fibrothecoma. Here's a type 2 curve that has an initial slope that is less than myometrium, but then proceeds to plateau. This may be seen with borderline tumors. A type 3 or high-risk curve has an initial slope equal to or greater than the myometrium and then plateaus, and this is more commonly seen with high-grade serous carcinomas. So I've talked to you about lesion morphology and vascularity. Now, how are you going to keep all of this straight to determine the O-RADS score? Here are the assessment category tables for both ultrasound and MRI found on the ACR website. When characterizing an ovarian or adnexal lesion, try to think algorithmically, and these tables will assist with an algorithmic approach. But there are also separate calculators available for O-RADS ultrasound and MRI. The ultrasound calculator can be downloaded as an app, and the MRI calculator is web-based but can be accessed on your phone. So in conclusion, ultrasound and MRI are complementary modalities, and when available, use both. Tissue is always the issue. The amount, characteristics, and vascularity of soft tissue always governs risk of malignancy. And lastly, RADs are living documents. So O-RADS will undergo updates and changes the more we use it in clinical practice and the more we learn. Thank you.